So you have just removed appliances. Yeah. You advise some 1450 ppm for right root additional intervention is the most appropriate. So you can use this casein phosphopeptide amorphous calcium phosphate, and that should be after brushing, right? And rub on the teeth. So rub casein on the teeth after brushing at night. So option D here. A 13 years old girl is being treated with functional appliance. She has been wearing this for 9 months. And you would like to evaluate the treatment changes that have occurred before planning your treatment phase of treatment. Before planning your treatment phase, you have two cephalometric criteria, one taken before the start of treatment and the other taken today. Which cephalometric assessment method is the most appropriate for the comparison of two? So we can have this grid analysis that includes benches and pitchfork, or we can go for Bjork. So we already have benches here, so I will go for benches. This is a repeated exam questions. So option A. Patient with non-latex allergy came to your clinic and you are about to start treatment. What do you prepare? How do you prepare for such an appointment? Train your staff, yes. Use natural, arrange salbutamol, arrange oxygen cylinder, arrange 1 in 1000 epinephrine or adrenaline. Non-latex allergy, you are about to start treatment. What do you prepare in such appointments? Yes, Motas, your favorite question.
Yes, we solved it by A and E before.
It
So
should be a
enjoy.
great talk, and highly like what you should do your every effort, and the emergency truck should be available.
Yes.
Okay, so just give me a second then. Okay, I will keep it stopped, but I will send some in after this session. I will take a second opinion on this one. Why it's not Control P. And Control P is not working. So I'm going to choose option A, which I always choose to choose, but I will take opinion. That's what others say. A. You are carrying orthodontic treatment involving fixed appliances for a 12 years old boy. His treatment has not involved extraction, and upper and lower appliances were fitted 9 months previously. His oral hygiene is constantly poor despite several visits to see the hygienist. You notice some areas of discoloration at the first appointment, which you brought to the attention of him and instead this visit. I think we solved this question yesterday. And then we decided that we'll take photographs, apply not right varnish, take impression, remove attachment from the prior to remover note, remove his appliance, take photograph, defer cleaning up the adhesive for 2 weeks, no. Remove fix, clean up the adhesive, take photograph and discharge him to the dentist. And once the fillings are done, so we are going for the option A here. You are finishing stage of orthodontic treatment, which required extractions. You have used pre-adjusted advice bracket system with a 2 to slot. All spaces are closed, but you are now required third order expression of the bracket prescription, which is the most appropriate arch wire. So it's the bracket prescription, not like bending. So a heavy stainless steel wire would be good, right? So it can be a 21.5 TMA, or it can be a 20 stainless steel, right? A 20 stainless steel will fill the slot more than a 21.5 TMA. So I'm just selecting here a 21.5 TMA because that is more used, right, than a 20 SS steel. There's one question, if you remember, that which bracket will fill the slot more. So there, obviously, I do not have choice, right? But here I'm choosing this one for the reason that this wire is commonly used. So I'm going to choose E. Yeah, 21.5 TMA without bending. You review a 17-year-old girl with a mandibular asymmetry, which is affecting her occlusal plane, but not the dental midlines. So it's a hemimandibular hyperplasia because it's not affecting the mandibular midline. The TC99M scan shows increased activity of the right condyle. What is the most likely diagnosis? So it's a condylar hyperplasia, hemimandibular hyperplasia. It's not written, but it's not affecting the midline, so it cannot be an elongation. So it should be a condylar hyperplasia, but it should be a hemimandibular condylar hyperplasia. So I'm selecting option B. You see 11-year-old girl for assessment. She has a class 2 deep 1 incisor relationship on moderate class 2 skeletal base with increased vertical proportions and a 4 millimeter anterior wide. She has a 10 millimeter OJET and still in the late max dentition. In addition, she has a moderate upper arch crowding with palatal displacement of the upper lateral incisor and a palatal impacted canine. She has previously been assessed by another orthodontic to recommend a twin block appliance in the first instance to reduce her overjet. You explain to the girl mother that you feel that the appliance is inappropriate. Which features of the patient malocmine has the greatest impact on the TCN? So we can deal the impacted canine along with it, the palatal, but the lateral open bite, I think the increased vertical proportion, sometimes they say that may affect. Her moderate upper arch crowding, no. Her 10 millimeter jet, even for that, we are going to give a twin block. Her mixed dentition stage, no. Her increased facial proficiency open bite, her palatal impacted canine. So I think option D here. D, like we give twin blocks, and along with twin blocks, we have case reports where they have erupted the impacted canines, right? So that can be done. So if something is a bigger issue than that, that is increased work anti-open bite, there should be a high pull headgear combined, right? So anyway, D, yeah. So they mostly ask about the composition of stainless steel and nickel titanium. So in stainless steel, it's called 18-8 stainless steel, which is 18% chromium and 8% nickel. So option A here. Not this question. This one. The same question, I think it's repeated again. It's a 1.5 millimeter diameter, 8 millimeter length, and a short head. So the option C here. Eight-year-old boy, mixed dentition, come to you with a mesodense palatal to the central incisor. I don't see it here. No. The patient did not have any aesthetic concerns and occlusal disturbance. What is the most common appropriate plan for this stage? So when we look at it here. Okay, like the picture is not clear, might be in the middle, there's something. So we can wait at this time. If it's not hindering anything, we can wait. Extraction it later in the permanent dentition, yeah, we can do it. Like we have to extract it. If it's like what interfering with the tongue function, we can even extract it right now. So sometimes they show a conical one, right, that might be interfering with the tongue function. So if the patient is not hesitant for the removal, then you should remove it at that time because it may causing a tongue injury. So I don't see anything here. If it's in the bone, you can leave it. Like I believe that it's not here. Yeah, anyone can see the mesodense here erupted because sometimes it's conical, right, and erupted. In those cases, if the patient is not like against it, then you can extract it now.
Excuse me, sir. If there's a difference in the alignment of the two teeth, so does that matter? Okay, it's destroying the alignment. We have to
Not
extract
at
it.
this stage. Not at this stage.
Okay.
We cannot do a complete fix orthodontics here. The only indication is that if you see up, because sometimes they do show one, and in those cases
Yes, sir.
they have a conical, and it's here, right? So people go with this
Right.
option because they feel that this is impeding the tongue function, right? And is a
Ye-
potential source of
Yes.
injury. So they do extract it.
Yes, sir.
Unless in the scenario they have written that the patient is not willing to go local anesthesia. So then you can skip it, like you can grind that tooth, right? And then you
Right, sir.
extract it later on when the patient is more adult.
Right, sir.
So right here, I do not see it. Might be it's in the bone or it's less visible. So that's why I'm selecting the option A here. But if you see one that is conical, then you should remove it. Like it's erupted, it's on the lingual side. This 11-year-old girl reported difficulties in breathing through her nose, in addition to narrow, high-vaulted palate and anterior convite, which occlusal feature you are most likely to find in oral examination. So he's a mouth breather, or she's a mouth breather, in fact. So reverse project, no. Proclination of the mandibular incisors in mouth breathers, less likely. Proclination of the upper, yes, to some extent, but not always. Mostly these features are in thumb sucking. Posterior crossbite, yes, in many cases. So I will select posterior crossbite here. A 40-year-old patient is undergoing pre-surgical orthodontic treatment with the upper left 4 extraction, while the upper right 4 was extracted 9 years before commencing the treatment. After 12 months of pre-surgical treatment, the extraction space was closed on the left side but still open on the right side. What would be the most common reason for delayed space closure? So space closure on 1925, I know. Increased bone density, yes. Hair integration. Actually, for this question, I'm selecting option E because they show a OPG. And in that OPG, the premolar is tipped backward. Right, upper left 4 was extra. Yeah, so sorry, the canine is tipped backward, but the root of the canine is, at the mesial aspect of this sinus, right? So I'm selecting this one. Otherwise, if I haven't seen that OPG, then I will select this increased bone density then. Like mostly they are all gloss rich, and because of that reason, the canine is not being retracted. But here I'm selecting E because I've seen one OPG in which it's very clear that the canine root is impeded and like its distal movement is impeded by the sinus. So option E here. I told you based on the OPG I have seen in the past. So chin prominent, right? A straight profile. It's not a convex profile. So anyway, 18 years female attend for joint orthodontic orthognathic clinic. She presented sticking out teeth and a lower jaw. You plan to carry out pre-surgical orthodontic in preparation of orthognathic surgery. What is appropriate surgery to address the patient concerns? So we have a class 2, half unit class 2. The nasolabial angle seam obtuse. The nose is prominent. We cannot do a mandibular setback. right? We can do a mandibular maxillary setback. So it's a mandibular advancement along with genioplasty. So bilateral sectional split osteotomy, advancement mandibular maxillary setback, no. BSSO and reduction genioplasty, yes. Option B. BSSO setback, no. Maxillary setback, no. Maxillary setback, no. So option B is the only right option here. This 14-year-old girl attend for assessment. She has a class 2 deep 2 maloclean with a reason well-aligned arches, with exception of the lower left second premolar, which is clinically missing. The space between the lower first premolar and the lower permanent molar is 5 millimeter. You take the following radiograph. What is the appropriate plan for the management of this girl? I think when she shared, the X-ray was not loaded because we need to see the X-ray. Surgical removal of the destrius molar and lower second molar, surgical removal of the destrius molar. I'm going to skip this one because I think the X-ray is not loaded here, right? Because this decision should be made on the X-ray. Dr. Hani also see if there is X-ray with this picture, but I think there would be X-ray. It's not possible.
Okay.
What does the ultimate tensile strength represent on the stress rate curve? So this is ultimate tensile spring back, right? On the x-axis is like here, it shows a spring back. Okay. If the patient has a displacement of the TMJ and a cross bite to the right side, what would be the best sentence to describe the position of the non-working side condyle in the glenoid fossa? So we can just suppose our own jaw, right? So what will happen to that? Yes, any idea what will happen? Yeah, so
B.
this is a joint, right? So best intent describe position non-working side in the glenoid fossa. So the working side is the side with the crossbite, right? Suppose this side is crossbite, so this will go outside. Chin would be deviated on the working side, so that's why like they would be going in this side. So if the chin is deviated to the other side, so this side would be moving medial. So we'll select the options which are medial. We have three options here: medial, superior, no. We remove the superior. So inferior and anterior on the right side. No, has a cross bite to the right side. Yeah, B. Because the left side is the non-working side. See, I selected medial first because this is medial. Then I have to select the left side, and that ends here. Because all other sides are the right side. The non-working side is the left side. So the option B here. If the patient has a displacement of the GMJ and cross bite to the right side, what will be the best sentence? Okay, I open the same line. I think it's shared again. If the patient has a displacement of the TMJ and a cross bite on the right side, yeah, it's the same, 2 times shared. You see a 14-year-old boy for continuation of his orthodontic treatment. He completed an 8-week period of rapid maxillary expansion. He has well-aligned arches, and you have to immediately plan fix appliances. What is the most appropriate next step in the management of the patient? So 14 months has completed 8 weeks of expansion. Usually for 4 weeks, you go for 4 months, 3 to 4 months for as a retention period. Secure RMA appliance putting components screw and review in 1 month, no. Remove RME and fit polymer retainer, no. Leave the RMA appliance in place, review in 1 month, no. Secure RMA appliance and review in 3 months, yeah. So the option B is good. Like at one place they have written 4 months in handbook, others like 3 months. Okay.
Their 8-week expansion is enough. Like if they've said so,
It
is it
depends
not
how
too
much
less?
extension is required.
Yes, sir.
Like it depends how much cross bite is there. Like sometimes we use this 8mm expander, that's more than enough. Other times we use 15mm or 13mm.
Yes, sir. Right, sir.
So a 10 years old female is referred for orthodontic assessment. Her medical history includes an overactive thyroid, which was managed through radioiodine treatment. Okay, you cannot palpate their canine in the buccal cell case and you suspect it's infected. You decide to take radiograph to locate her canine. Her mother expressed concern about the radiation exposure to the daughter thyroid canine. Which combination of radiographic investigation minimizes exposure? Lateral ceph, no. And standard, like we use these orthopanogram and periapical, lateral ceph, and these two periapicals. If we are talking in terms of like minimize exposure, then two periapicals will minimize exposure. That's why I'm going to select E because they have the limited dose now. So option E here. A 11-year female presented with syndrome known as ectodermal dysplasia with intraoral features you would expect in this case. Absence of clavicle, but they asked about intraoral features, so it would be hypodontia. Option E. A patient was fitted with fixed appliances a few days ago. A weeks after the bond-off visit, he presented with loose upper first molar band for the first time. Most of the GIC was left on the tooth surface rather than the inner surface of the band. What is the most appropriate failure? Many times they also write that there was open bite on that side because it can be due to trauma. Right, it can be due to trauma. That's why in many questions they write that there is a lateral open bite. So moisture contamination is less issue because tooth surface because adhesive was left on the tooth surface, so this is not an option. So high powder liquid ratio is not an option. It can be low powder liquid ratio. Yeah, that can be option. That can be option. If prismatic enamel implementation, this is less likely. That's present on all the surface. So I'm going to skip this one. So I have two options here. Both are correct, right? I'm selecting option B. As I told you many times, they even write that they have this open bite, otherwise both options are right. So I'm selecting option B here. What is the duration post-fracture direction of force given? So it's 30, 14 through 16 hours, 30° 400 gram is correct. 15 or 30, 15 hours, it's very close. Like they have mentioned the range usually 14 to 30 degrees. 14 hours, 30° down, 30 degrees down, 400 gram per side, 400 gram per side, 10 hours, no, 20 hours, no, 10 hours, no. So we have two close options here. I'm
Sir,
going.
orthopedic force in Kuban is 12 to 14 hours.
Yeah, sometimes they also wrote 14 to 16. I'm selecting option A.
Yes, sir.
20 years old female with cerebral palsy. She has a partial hearing loss and poor motor skills. She cannot write and attends for orthodontic assessment. She has limited verbal communication and she uses adaptive computer softwares. Her carrier explained that also she has language limitation, so the patient will give the consent herself. Her carrier gets back to you 2 days later to confirm that the patient wants to go ahead with the option of fix. What is the most next step? Attend the patient home so that you can confirm, like you cannot rely upon the carrier, care provider. So attend the patient home so that you can confirm the patient consent through computerized speech software. Yeah. Because the care provider is not the person for an adult patient. Cannot be offered because the patient no. Ask a colleague no. Ask another care no. So the option A is correct here. So 7 years old boy had displacement fluid. What is the most important reason for carrying out treatment for him at this time? To take significant space for the eruption of the lower lateral incisor, to maintain arch symmetry, to prevent proclination and attachment loss of the lower labial segment, to improve aesthetic, prevent future development of temporal mantle. TMJ is less developed, to improve aesthetic, no, to prevent proclination and periodontal attachment loss of lower central incisor, yes, that can one reason. Also, pseudo class 3 can develop if they have written it here, to maintain arch symmetry and prevent the need for orthodontic treatment in the full permanent dentition. Option B, to make sufficient space for the eruption, no. So one is to maintain arch symmetry and prevent the need of orthodontic treatment in the permanent dentition. I'm going to select C here, but mostly we used to do it to prevent pseudo class 3 because right now the patient might have a pseudo class 3, right, because of these premature contacts. So I'm selecting C here, the third option. This 9-year-old boy has been referred for advice on the manufacture of his impacted lower first permanent molar. What is the most appropriate plan for the immediate management of this boy? Open exposure of the lower left first permanent molar and wait it to erupt. Upper removal appliance to include surgical removal. Like we have discussed this before, to me, like it seems to be a soft tissue impaction. I will do open exposure. Yes, like the upper molar should be intuited, but the first thing is that the lower molar should be exposed. So I'm going to select A. A female patient underwent jaw surgery 2 years ago and is now complaining of progressive increase in dental open bite since a year. So it seems like condylar resorption then, if it's written, otherwise it would be a condylar sag. Clockwise movement will condylar, not linear impacted condylar. If it's after 1 year, I will select condylar resorption. Option E here.
Dr. Harris, sorry for the interruption. If both are written, we'll choose the condylar sag, right?
No, it's after 1 year started.
After 1 year. Okay, so if after 1 year, idiopathic condylar sag. If less than 1 year, idiopathic condylar resorption.
It's no. If it's in first 6 months, 7 months, it's a condylar sag. If it's after 1
Okay.
year, after 6 months, it's a idiopathic condylar resorption.
Okay, doctor. Thank you for that.
What is the most likely reason for the early removal of TAD and catch devices? If you remove yourself, then it is damage to the root surface in teeth, option E. If it's a failure, then it's the mobility. A 9-year-old attempts to start orthodontic treatment. He has a unilateral posterior crossbite on the right side with a displacement on glare. Your lab has constructed a quad helix appliance which will now fit what is the most appropriate way to activate the appliance. It's a unilateral crossbite or a bilateral crossbite. The posterior activation is half unit, half molar width activation on each side, right, for posterior expansion. So expand by half molar width on the each side. Like in the new handbook of orthodontics, they have written 1 molar width, but that is wrong. So in the second edition, I will just follow the second edition here. Expand by half molar width on each side. So option E here. Manufacturer decrease the quality of sodium phosphate in the alginate. What does it have on the working of on the working time? So what's the function of sodium phosphate?
It's a retarder.
Is it sodium or calcium phosphate?
No, it's sodium phosphate.
Can be both.
Sorry.
It can be both.
Yes, it can be both calcium phosphate and sodium phosphate. Both are retarders.
Oh, let me double check.
Yeah.
A, B, C, D, E, F, G, H, I, J. Where is material? Start in M patient. MIH material, yeah. Yeah, sodium phosphate delays the reaction constant, therefore extends the working time. Okay. So they have decreased, so the working time would be decreased. Option A. Manufacturer decrease the quality of sodium phosphate. The same one. Okay, then repeat it again and again.
Sir, when the retarder is decreased, the working time will increase, sir, or decrease?
The working time will decrease. Retard the setting, right?
Right. Okay,
So
sir.
it's retarding the setting. So it's increasing
Right, sir.
the working time. So here we have a headgear and this one. A patient has just a headgear fitted with appropriate vector as indicated in the diagram. So most likely if they are showing this vector, it's a high pull headgear. To wear the headgear for 50 grams, for what will be the effect? So it has a distal pull. It's the line of action of force passing through the center of resistance. So it would have a Baldy movement, right? And it would have also an intrusion factor. So this is wrong, not it's intrusion and distal movement. Baldy distal movement of the molar, yes. Mesial distal crown movement. So basically this is distal, Baldy distal movement with intrusion. I'm selecting this one, but I told you that there should be intrusion too. Because the first one is Baldy movement. Yeah.
Sorry to interrupt, but the inner bow should pass through the center of resistance, so we can
Not
say
in the
bodily movement.
See, the inner bow is always in the band. It's a line
Okay,
of
so the
action.
arrow?
No, it's not the outer. Sometimes we have a shorter bow, right? It ends here. Other times it ends here. So it's a line of action of force. Like this line of action of force, like where you bring it. Because we can have bodily movement in a low pull head here. Because you can increase this like this, the force can come from the bottom, right? And pass to the center of resistance. Like you bend it this way, slightly long, And when the forces come from the neck, they pass it through the center of resistance. So it's the line of action of force that is most important here,
Okay.
not the
Uh,
inner
Dr.
force.
Dr.
Inner
Harris,
force
sorry
is
for
always in the band.
All right. Okay. Yes. Thank you.
Dr. Harris, sorry for that, but here the force of the action is above the COR, doctor. So shouldn't be option A?
See, the force is passing through the center of resistance. It's at the level of trifurcation.
Yes, sir.
So it's passing from there. So it's a bodily movement.
Okay, doctor. Okay.
I told you that the option, this option should be within Trian, and this option should be bodily. So I'm selecting bodily because bodily movement is more important here, because it's a high bull head gear, so there would be some Trian vector.
Okay, sir.
Might be very minor, but there would be some Trian vector. But bodily movement is more important.
More important. Got it.
Okay, so I see here. A picture with white spot lesion on the upper right, one diagnosis. Similar picture, upper and lower occlusive picture were not clear at all. You could not clearly tell the status of the sixes. I felt they were mildly hypoplastic. Yeah, if they were hypoplastic, then it's a MIH. If the incisors are hypoplastic, the molars are hypoplastic, then it's a MIH.
Sir, if the molars are not hypoplastic, then it would be demineralized.
Yeah, then it would be some demineralization. Then we can select, like, it cannot be a fluorosis because other teeth are normal. It cannot be a
Yes, sir.
melanosis perfecta because that is generalized condition. So it can be demineralization. The enamel is there, so it cannot be dentinogenesis imperfecta. Then it can be option D then.
Right, sir.
So 18-year-old male has a medical history of severe asthma and is regularly taking salbutamol. During an orthodontic activation appointment, the patient has asthmatic attack. What would be your immediate course of action? I will still follow first oxygen and then salbutamol. Not cortisone. Administer concentration oxygen salbutamol, option D. So, but the first one is like make the patient sit in upright position. Is it upright? A supine position for the asthma? Yes, Dr. Hiba.
Sorry, doctor, what did you say?
For asthma, is it upright position or supine position?
No, we should
Sir, it's
avoid the
upright.
supine position. We should avoid. Yes.
So it's more better this option than this option, right? We have two close options here.
Yes. So option D, I think.
Why not option B?
No. Yes. But there's no salbutamol on option B.
Yeah, but they asked the first line of defense.
But doctor, it's a severe asthmatic attack. We should give him salbutamol as well immediately, right?
But upright position, sit patient upright. See, even it's a severe epilepsy attack, we first clear the area so the patient do not injure himself. Right. So
Yes.
the positioning is important. So sit the patient upright, then administrate oxygen, then this one. So I'm selecting the first two of them.
Okay.
So I'm going for the option B here. Patient has to be assessed for growth modification, which method is best for growth prediction. So we have serial hand and wrist, which are not done in UK. We have serial CVMs, which are again not reliable. We have growth distance curve, which is not reliable, like it's less reliable, or in fact not reliable to see the peak height velocity. So Peak velocity curve versus height assessment.
I think it's same, Doctor.
Yeah, it's same, but I think there should be growth charts for the same patient. It should be a growth distance curve, a growth velocity curve. Here they just write peak height velocity. We cannot know peak height velocity like by what methods, because Henry's is also to see the peak height velocity. So I'm selecting this one because we make growth charts. Like we have two growth charts, growth distance and growth velocity curve. So we'll go for the measurements of that patient every 3 months, 4 months, at least 3 measurements to see that the patient has the peak height velocity. So that's why I'm selecting E.
Selecting C or E?
Selecting C. A review of 16 years old male with a facial asymmetry on the orthodontic orthognathic clinic. He has been monitored for 12 months. During this time, his asymmetry has progressively worsened. What is the most appropriate next step in the management of this patient? So 16 is still growing, right? So we can do optical surface scanning to keep monitoring, right? Because this is better than this one. So this is not a better technique. This is not a immediate surgery. It's not a better. So the option B is the only right option, seems to me here.
Why Doctor
Sir,
option
why
B?
not to monitor?
Yeah, we are monitoring with the optical surface scanning. They said that now the best is the optical surface scanning to monitor.
But already worsening in the case.
Yeah.
So
So
what will help
just went
us
to the handbook
optical
of orthodontics yesterday, Mutaz, and it said that the non-invasive method, like once you have done this TC99M scanning, the non-invasive method is previously they were doing photographs and models. Now it's the optical surface scanning to monitor, right?
Mhm.
So we can superimpose them. Like in monitor, what we'll do in monitoring, must have something to monitor, like some objective methods to monitor,
Yes, sir. Thank you.
right? Like if we just seeing the patient every visit, it's a subjective method. So we cannot use a subjective method. We need objective method, right? To be very sure about it, that the things are not changing. So the objective method is optical surface scanning, and they also have written in the handbook of orthodontics, in the chapter of orthognathic surgery.
Okay.
So option B here. Yeah, option B. A patient was fitted with fixed appliances few days ago. Weeks after the bond-up visit, he presented with a loose upper first molar band for the first time. Most of the GIC was left on the tooth rather than insufficient band. What is the most? I think I will select the same. It's the same repeated question. I told you many times they write that there was a lateral open bite. So heavy occlusal forces, right? But there would be other problems too if the band is coming in occlusion. So I'm going to select low powder. Liquid ratio means the liquid is more. That's why the adhesive is more on the tooth side rather than on the band side. So the option B here. So 8 years old, attend for assessment. She's a mid-maxentition with erupted incisor, first premolar. She has a midline diastema of 2 millimeter gingival margin and 4 millimeter incisively. We decided that at the gingival margin, it's more important. So if it's 2 millimeter, might be due to the cyclic stretching stage. Because if it's more than 2 millimeter at the gingival margin, then we need to interfere. So she has a low frenum attachment and blanching of the frenum interdentally. Even then, we do not like going to interfere. We interfere like when we have these, some, supernumerity, something like that. We're not going to for a, frenectomy at this age, closing the spaces. So I think reassure and monitor. Option A.
So it's
Yeah, go ahead.
4 mm inside the knee. So still,
Yeah, it's basically 2 mm at the gingival level. When you succeed more at the gingival level, then that's a problem. It's through and through, or especially at the gingival level. Then it means there's obstruction there.
okay.
And also, sir, patient is 8 years, so it's ugly stage.
Yeah. See, they say that even in ugly duckling stage, if it's exceed more than 2 mm through and through, right, then it's a problem. So a 27-year-old female presented with a 3-dimensional enlargement of the condyle means mandibular hyperplasia. It cannot be elongation on the right side. So it's a unilateral. So I think there's a cant in the occlusal plane, everything the same. So mandibular hyperplasia, option A.
Doctor, what is the difference between the hyperplasia and elongation? Is it the same option?
No, hyperplasia is a 3-dimensional problem. There's a cant of the occlusal plane in hyperplasia. If you go further, you will see like what the distance from the root apex of the molars to the inferior alveolar canal is increased on the hyperplasia side. Also, there is a lateral open bite on the hyperplasia side. While in elongation, it's a 2-dimensional problem. It's only the body of the mandible that is increased and the midline is shifted. Right.
Sir, why not condylar hyperplasia?
Because it's only on one side.
Okay.
It's hemimandibular.
Okay.
A 9-year-old patient with fused upper central incisor who is in the mixed dentition, what will be the most initial radiographs? We decided we will go for the upper occlusal images for these cases, but I will have to double check. But most of people go for these upper occlusals. Anyway, we are solving this by upper occlusal, but I will let you know. If I don't, just keep a note of it and leave a message on WhatsApp. I'm going for option C here. Okay, now this is mix up. The patient has pre-adjusted edgewise appliances to start. What is the likely reason of placement of R5 bands? To allow simultaneous use of class 2 elastics, yes, that can be done. Activation, achieve differential extrusion, like they are at the same level. When the loops are at different level, means like this, and this way. So you are doing, because the two legs, alpha and beta legs are different height, then you can do this differential extrusion or intrusion. So this is not the case here. To maintain incisor torque while space clear, no. Overcome frictional resistance while space clear, yes, that is one of to achieve differential intrusion. So I will go with overcome frictional resistance, option D here. That is more important than using class 2 elastics.
Dr. Harris, what is the right answer? Please again, somehow the options are hidden below the picture. I'm not sure. So
See,
could you please repeat what is the four?
Both alpha and beta arms are at the same height, right? So it's not a differential extrusion or intrusion, right? So they are not for, some people also use class 2 elastic, but they are using in the both arches. So I will choose it that they mentioned that to overcome frictional forces when space clear is slow. This option.
And how will these bends overcome the frictional forces?
Because we are going for not going aiming friction here. These are frictionless mechanics. Loop mechanics are considered frictionless mechanics. We're not aiming for guiding mechanics.
Okay, thank you.
So D here. You are treating a 27-year-old male who has a history of intravenous drug abuse. He's HIV positive In addition, has history of hepatitis B and C. He also has a cold. So during his bond up, you catch up his lip and probe and start bleeds. You nursery stab herself with the probe. So bloodborne, they say that hepatitis B is the most common, even according to WHO websites, to spread. So I'm going to select E. The 7-year-old boy attends for orthodontic assessment. He is unconcerned about the appearance of his teeth. If interceptive treatment is not carried out, what is the most significant long-term consequences of this patient? We have solved this question because there is a mesodense here and the central is coming from outside. So it would be a recession associated denuded margin of the lower right central inside the tooth. No. Displacement of no. Impaction of the right permanent teeth. 1, 2, 3, 4. I think there's one other option which is not showing here because we always, poor periodontal health associated with the upper central incisor tooth because it's eruption through the non-attached gingiva. Option E here. We also solved this one. 80 MPa is too much, right? It should be 13 to 18 MPa. So it's same as the no. It's signaling less no, slightly less no. It's signaling more than the ones. Slightly more. So option D is significantly more. Option D.
The normal is 13 to 18.
13 to 18 MPa.
Okay, sir.
What is the mechanism of action of composite? It's a free radical addition polymerization reaction. So I'll select addition polymerization. It's a main reaction, and in that it's a free radical formation. So option D here, E here. Yeah, E.
Mr. Harris,
Yes.
I have some question.
Yes.
For severe crowded cases, which property of wire we need? Is it resilience or is it spring back?
Range or spring back. I told you both have been used, but range is more used in the literature than the spring back. Like the wire should be very.
What's the?
It should.
So what's the difference between spring back and range?
It's hard to like differentiate. It's hard to differentiate. There's like more deformation. Like the definitions are very close. The range of activation of the spring back is range of activation wire, and still it can come back to its normal shape without permanent deformation. So it's almost the same, but if you see the literature, the word range is used more. Like they say that night I have a greater range than spring back. At few places they have written spring back because we discussed this question a lot in September 2023 exam. And at most places, the word range is written. Both properties are very close to each other.
Okay. Another question regarding roller coaster effect of bracket. And I know Wagon wheel effect, but what about roller coaster effect of the bracket?
See, last time the question came that was length affecting the spring back and the range, right? For the roller coaster effect, when you apply these heavy forces, right? So what happened, closing space in this thing or incisor retraction, there is lateral open bite appearance and the incisor also lose their torque, right? So mainly this is opening of the lateral open bite under heavy forces.
And loss of torque.
Yeah, the torque also lose or bites slightly increase. But most
also. Go ahead, Dr. Sorry.
But they haven't given roller coaster effect in the last two diets.
Okay.
Sir, I have a question regarding the orthodontic composition or before bonding, orthodontic bonding. Is it necessary we can go for pumice prophylaxis?
Yes, this is for self-fetching primer, yes. Even I
and it is with,
even
it
I
is
shared
with
the
a
new document.
brush or a cups.
Sorry?
Is it with a brush or a cup?
The two are the same. Like it's up to you how you do the prophylaxis. Like I
Okay,
didn't
sir.
went
Sir,
to
if those
detail.
same, sir,
Sir,
there is
there is
MCQs both are here.
Both separately written with a
Sorry?
cup or with a brush. Sir,
Sorry?
the question Qasim is asking about with a cup or a brush. In a question, there are both options separately, even with a brush and with the cup. And in
Usually,
handbook third, they have wrote okay, with a cup or brush.
yeah. So usually they
Both
say,
are, but
yeah, they say that
instead
brush
of-
remove more enamel than a cup. Again, that
okay,
it's
okay.
not an evidence-based answer, but if you see the practices who do this scaling and polishing, they prefer a cup over a brush. The brush usually remove more adhesives. Sorry, the more enamel layer.
Okay, okay.
Right, sir. Thank you.
Yeah, so it's option C here, Dr. Iman.
Okay, doctor, if there is any difference between the previous question, can you back just yes, this one?
And difference in the previous question?
Yes, in the same, yes, this one up here, yes. The same question, or there is different here?
See, I think one was X-ray and one was a chemical of X-ray, I think then.
Yes.
Here you are disposing the film, and here she's aware of the waste chemicals. So this is special waste. Here they are going for the chemicals.
Okay.
So these are two
Okay.
different questions.
Okay, doctor, thank you.
So for the pending question, I do have one option. I think like I will try to make a video then, right, if people cannot attend, because there are some pending questions by the candidates. So I will try my best tomorrow at 8 a.m. I think the UK time is changed now, right? So 8 a.m. UK time, they have increased with 1 hour. So if you people are available, you can join, right? You can ask me on the WhatsApp. I will share the link with you. So I'll try the pending questions, right?
Sir, what's Pakistani time?
You can just check it on Google.
It's 12 a.m. in Pakistan, I think.
Just the time
12
zone have been
PM.
changed in UK.
So, Dr.
Yeah,
Karen,
PM.
I'm just
PM,
double
PM.
checking. So tomorrow you said at 8 a.m. UK time you are going to be like available for Zoom session?
Yeah, I will do, because there's some pending question from the candidates, not from me, right? There are 100.
Okay, but will we have an option to participate as a
It's up to you.
audience?
Like I can share the link, Zoom link.
Yes, yes, please. So the same link will not be valid at 8 a.m. tomorrow?
It would be valid. I will start in fact, the same link.
Perfect. Fine, fine.
It's already pinned in the WhatsApp.
Excuse me. Excuse me, sir.
Yes.
The question you have solved about polymerization reaction of
Composite.
the polymer. Sir, when we search Google with the thing that what is free radical polymerization, it defines it up addition polymerization, which includes free radical generation.
Yeah, so that's why addition went for
And-
addition polymerization. In that addition,
But when we,
yeah,
I was confused what to choose, free or addition. Free doesn't mean the whole thing addition plus free radical, because addition has further categories in which there is free radical is one of them. Some are cationic, some are anionic. But while when we check for free radical polymerization, it says it is additional polymerization. I was confused. It's just wording difference, but I was confused.
see, they are just given this basic like addition polymerization of free radical. They haven't given these cationic or these reactions till date.
Okay.
So see you.
Okay, thank you, sir.
Yeah, because I have another commitment in 10 minutes. So see you, everyone.
Okay, sir. Thank you.